Okay, so this session is going to be about preventing child and adolescent firearm injuries within healthcare settings. And we have three great speakers. So I'm going to talk for a few minutes, and then Dr. Beidas will talk, and Dr. Hoffman will talk after that. I do not have any disclosures other than funding sources. I thought I would start this session by talking a little bit about, as you heard earlier, a number of scoping reviews were conducted from the FACTS Consortium in the first year of the project. And one was looking at what is being done in healthcare settings around primary prevention for firearm injuries among children and adolescents. And the team that looked at this reviewed 46 articles broadly focused around what healthcare screening tools are available. And the team found two articles that really focused on screening practices in healthcare settings, and there's the FIGHT score and the safety score, which was work done here at Michigan, both of which have yet to be validated, but are promising for predicting involvement in interpersonal violence. But we still have a need to do greater screening around who needs to be screened for lethal means counseling, and who's at risk for unintentional injuries, and how best to screen those populations of parents and adolescents. Should we figure this out?
Is this the next one?
That's the next one.
Okay.
Not appearing up there.
Quit. Let me refresh this. I'm sorry.
So the team also looked at safe storage counseling interventions and found that in general there is some evidence around counseling for safe storage, and that the evidence is stronger when that safe storage counseling is accompanied by providing firearm or gun locks. And I know Dr. Beidas will talk a little bit more about some of the work that was done with Dr. Barkin's study for that. In addition, the team looked at healthcare interventions that had been done with healthcare providers, and found that there was some interventions that had shown that we could increase the self-efficacy of medical providers to provide safe storage counseling, but it's unknown really whether or not that translates into actual behavioral outcomes, changing behaviors among patient populations. And then the next slide would have talked about their review of interpersonal violence interventions that have been done in healthcare settings. And really what we see is, so the review here showed that there's been a number of high-quality randomized control trials that have looked at general violence outcomes, so say for teens and SYNC, and some studies that have looked at decreasing weapon carriage among adolescents using either motivational interviewing or combinations of motivational interviewing and cognitive behavioral therapy and collaborative care approaches. But there's a lack really of rigorous studies that have looked at firearm-specific outcomes and whether or not these same types of interventions are effective for firearm-specific behaviors. And then in addition to that, there's a number of programs out there that look promising in terms of their being able to provide care management to youth out of the emergency department or hospital setting, but we really don't have rigorous trials of those outcomes yet. So there's more work to be done here at the sort of basic efficacy level. So I'll talk a little bit about some of the work that we are doing here on interpersonal violence prevention to try and develop that evidence base for these types of interventions. So I always start with telling people why I think it's important to do these kind of interventions in the emergency department. Emergency departments provide a teachable moment for youth who are at risk. They're often there for a violent injury or for behaviors related to their violence involvement, and it can be a really powerful time to do an intervention. And they may be missed in school-based prevention programs if they're at risk and not attending school. And I think it's important to start these interventions in the emergency department. I think inpatient hospital programs often will miss even up to 50% of firearm injuries that are discharged home. And many youth don't get regular primary care, especially in urban settings. And we do see these patients. So about 20% of the patients that we see that come into the emergency department for a violent injury are there for a firearm injury. And there's a high risk of them returning within the next 2 years for repeat violent injury and for being involved in firearm violence at multiple levels. So up to 60% in one study that we did found that those youth were involved in firearm violence within the next 2 years, either as the aggressor or the victim of an event. And almost half end up engaged in the criminal justice system. So there's a lot of work here to be done in terms of prevention of these outcomes and allowing youth to really move along the developmental spectrum. And this time when they're in the emergency department really is a high-risk time for retaliatory violence, and we can hopefully intervene with some of these interventions to prevent that retaliatory violence outcomes. There's a lot of different places along the spectrum where we can intervene. So I'm going to talk about first some work we're doing around primary prevention, so youth who are at risk but are not yet there in the ED that day for a violent injury. And then I'll talk about secondary prevention interventions, interventions that we can do with youth who are there for violent injury to prevent that next violent injury. So a lot of this work builds on the Safer Teens intervention, which was done by a number of the investigators in this room, Dr. Cunningham and Dr. Walton. And this was a brief intervention that was done with youth who came into the emergency department who had a history of fighting, and a 30-minute counseling session delivered by a therapist in the emergency department decreased their involvement in violence for out to a year after their ED visit, just with that brief 30-minute encounter. So one of the things we're looking at now is how do we translate that to outcomes around firearms? So how do we take that intervention, which was a brief intervention done, a single session intervention, and ramp it up to multiple sessions with youth that pairs an ED session with remote therapy delivered sessions after the emergency department that combines this motivational interviewing behavioral change intervention with delivering cognitive behavioral therapy around skills for navigating violent situations, and also providing resources through care management. And then in addition to that, providing and capitalizing on technologies that youth use. So this study, we're testing not only the behavioral therapy delivered by an interventionist in the ED and after the ED, but we're also putting a smartphone app on the kids' phones. And we're using that app to deliver therapeutic content in between their remote therapy sessions. So we are collecting survey data on alcohol and drug use and firearm behaviors and violence behaviors every day during their intervention period. And then we're using that data to deliver tailored messaging, both motivational interviewing messaging as well as cognitive behavioral therapy messaging, as well as resources both in the community and tips and skills to stay safe with firearms and firearm behaviors. In addition, we're capitalizing on the cell phone's use of GPS to help youth identify what are high-risk hotspots for them and deliver just-in-time messages at times that they enter into those hotspots, either places where they've used substance use before or where they've gotten into fights or where they've seen or been exposed to firearms. And then the app also can prompt resources that the youth can access just in time or at the direction of their therapist during their individual therapy sessions. And currently we're also testing as part of this, how do we use this technology to help engage youth in these interventions? One of the issues with this type of work that's been done before is you see a drop-off in youth participation over time. And how can we use engaging strategies that are evidence-based in the literature for adolescents and use that to help engage them in the intervention? So daily inspirational memes, prize-based remuneration techniques for daily survey completion, as well as streak messaging for behaviors that they do that are positive, and capitalize on that to help engage them in the intervention and encourage their participation over time. Before I go on and talk about the next study that we're actively doing, so this is currently in the field. We're pilot testing this intervention, and we're pilot testing the app, and we're collecting data on essentially both the preliminary efficacy data to take this and scale it up to a larger scale intervention with youth who carry firearms. So I said that sort of focuses on youth who come into the emergency department who may be carrying a firearm but are not yet there that day for a violent injury, and really focuses more on the upstream kind of primary prevention in an emergency medicine context with youth who are at risk. And I'm going to switch gears for a minute here and just briefly talk about a larger scale study that we are starting now that's on secondary prevention. So among assault-injured youth who come into the emergency department, I told you that about a third of them come back for a violent injury within the next 2 years, and about 59% are involved in firearm violence over that 2 years. So what do we do with that kid who comes in with a violent injury to prevent them from having those repeat violent experiences? And so we have a new NICHD-funded R01 trial that is going to test 2 versions of an intervention. So One is capitalizing on, similar to the intervention I mentioned before, a multi-session behavioral therapy that partners motivational interviewing and cognitive behavioral therapy and care management delivered in the ED and then over subsequent sessions to these youth who come in, that mirrors a lot of the programs that are out there currently and tries to develop that evidence base for them. And the second arm of the study is really looking at how do we step up or down the intensity and the modality of that intervention depending on how the kid is doing. So this involves a reinforcement learning algorithm. We will measure daily how they're engaging in both the intervention as well as their violence behaviors, and that will allow a computerized algorithm to determine whether the kid is progressing as expected, and we'll learn over time what works for which populations of kids and then what type of intervention to deliver. And so that's a more specialized intervention arm, and the idea there is to test whether this approach can be achieve as good outcomes as sort of a standard multi-session intervention at lower cost. And so we're actively starting to get in the field with that intervention. And with that, I will turn it over to Dr. Beidas, who will talk about implementation science.
Will you help me?
I don't know if I can.
Sorry. You deserve an extra round of applause for coping with the no slides situation.
Just want to make sure we got your right ones.
Fingers crossed, guys. All right. Thank you so much. It's such a pleasure and an honor to be here speaking about this work today. I want to start by acknowledging the many different sources of funding that have made the work that I'll be talking about today possible, including funding from the NIMH and the NICHD. Also, I want to say that it takes a village to do this type of work. So if your name's on this list, would you just raise your hand so folks can see how many of this team is represented in the room? It's almost half the room. So I just want to thank the world-class team that has supported and provided their valuable advice and insights into this work. I'm not going to have the opportunity to speak with each and every one of you today, and I know that there are folks live streaming, and so I hope we can keep the conversation going over Twitter. So please feel free to tweet at me at rsbeidas if you have questions that I'm not able to answer today. So I want to start just by orienting you to my worldview and how I come at this particular question. So I happen to be a clinical psychologist turned implementation scientist. And the goal of my work is really to reduce the no-do gap, to improve the quality of health services, to improve lives. And what I hope you'll take away from the brief 10 minutes that I have to chat with you today is that health systems are one of many viable places for us to think about implementing evidence-based safe firearm storage programs as a universal suicide prevention strategy. And then finally, just to orient ourselves to our shared mission, which Dr. Cunningham did so well this morning, we all want to keep youth safe, and that is our shared mission. So first, a little background on why this matters. Before I get to this slide, I just want to share that there's 130 suicide deaths a day. And that actually parallels the exact number of opioid use deaths a day, 130. This is a public health crisis that we must address. The rates of youth suicide is increasing in our country. You can see here a graph representing injury death rates for children and adolescents aged 10 to 19. The red arrow is by the suicide death rate. And what you can see underneath the red bar is that from 2007 to 2016, our suicide rate increased in youth 60% almost, to 6 deaths per 100,000 youth. And firearms happen to be the mechanism for half of those deaths, making that a really important target for us as we think about suicide prevention. A recent survey found that only 3 in 10 families store their guns in the safest manner, so unloaded and locked. So that also provides evidence for the opportunity to think about safe firearm storage. And Dr. Monato, who's here, just published a very interesting simulation study that showed that even a modest increase in safe firearm storage could save up to 32% of youth lives, and thus moving the needle on this public health crisis. So when I sat back and when our team was talking about where could we reach the most youth if we wanted to intervene to increase safe firearm storage, we thought long and hard about this. And we ultimately ended up landing on primary care, which is really the first line of defense for our health systems. And if there's any primary care pediatric docs in the room, which I know there are, I know we ask a lot of you. But it turns out that youth who die by suicide visit primary care in the time leading up to that, and they often don't visit mental health clinicians. So we're relying on you to help save our youth lives. So there is an evidence-based practice, which is wonderful, for pediatric primary care around safe firearm storage. Dr. Sherry Barkin and her team in 2008 published a study in Pediatrics describing the outcomes of the safety check. Now, the safety check is a bundle of violence prevention interventions, not only focused on safe firearm storage. However, I'm isolating the component related to firearm safe storage, the results of the study were quite promising, showing that parents in the intervention group had a twofold increase in safe storage after receiving 3 components. One was screening for firearms in the home. Second was a conversation between the clinician and the parent about the importance of safe firearm storage. And the third component was giving out free cable locks. So I'm presenting a span of research that we've been doing over the past 3 years, roughly focused on the following scientific questions, but I'm happy to answer any specific details as they come up in the Q&A. So the first thing I'll share is related to our wanting to understand what physician uptake of those 3 program components look like. Again, screening, a brief conversation, and giving out cable locks, especially given that national organizations such as the American Academy of Pediatrics recommends that physicians follow these guidelines. Thank you. Second, what are some barriers and facilitators to large-scale implementation or use of this program to help us plan for a wide-scale implementation? What do stakeholders feel that they need to be able to implement the program effectively? And are there any adaptations that are needed to make the program more acceptable? So I'll answer the first question for you. If you're interested in more details, we do have a publication on it, which is related to physician use of each of the 3 program components. Orienting you to the graph, you'll see that each bar represents one of the program components, and the y-axis represents the percentage of physicians who endorsed using each of these components rarely or sometimes. So if we look at it in this less conservative way, the majority of clinicians are endorsing using screening and counseling, and the minority are endorsing giving out gun locks rarely or sometimes. If we're to look at it a little more conservatively, looking at the clinicians who endorse doing these evidence-based components most of the time or always, we see that only about 30% of physicians report doing screening and counseling, and only 2% are giving out cable locks. Most of the time or always, representing a no-do gap, and thus where implementation science can come in. So we followed that quantitative survey, and I should have said that survey was with about 100 clinicians in 2 large health systems in Michigan and Texas. And so then we followed up that quantitative survey with qualitative work with approximately 70 stakeholders representing 10 different stakeholder groups. So this includes clinicians, it includes firearm-owning parents, health system leaders, representatives of national organizations, and firearm safety course instructor experts. And we use something called the Consolidated Framework for Implementation Research, which is a widely used implementation science framework to get at potential barriers and facilitators to implementation from 4 main domains. The first being intervention characteristics. So one of the things we heard from particularly our health system stakeholders was that the program has to be brief. It has to be 1 minute or less because our pediatric primary care providers are, very much weighed down with a number of different programs that they're expected to implement. We also heard of the importance of attending to outer setting factors. And outer setting refers to the broader sociopolitical context that you might be implementing within. And we heard about the importance of attending to our nation's firearm culture and ensuring that our programs aren't seen as infringing upon Second Amendment rights. We also heard the importance of inner setting factors, which refers to the clinics that we'd be implementing in, integrating the program into the electronic health record and into workflow integration, ensuring that there's leadership buy-in. And then finally, we heard about characteristics of the clinicians that we should be attending to, such as their self-efficacy in having this kind of conversation. So the wonderful thing about being able to do this in-depth qualitative work is that it then helped us derive a set of strategies that we can now test in a larger scale implementation study to accompany the implementation of this program. And I'm just going to highlight 3 that I think are particularly important. 1, creating a plan for whom on the medical team would be responsible for each of the components. 2, integrating the program into the electronic health record was one of the main suggestions we heard from our health system stakeholders. And 3, adapting the program. Now, the Safety Check is a wonderful program, but it's been 15 years since the program was developed. The context in our country has changed significantly. We've learned a lot from implementation science, and particularly our firearm-owning parents and our firearm core safety instructors had some suggestions about how we might adapt the program to make it more acceptable to firearm stakeholders. And that is what we're in the process of currently doing with generous funding from FACTS. Thank you very much. Dr. Pettit has a poster this afternoon about our adaptation process, so please go check it out. But essentially, we're taking information from our interviews from the study I just presented, the behavioral science literature to help us around behavior change and best practices from primary care to adapt the program. So for example, we're removing the screening step since we can offer cable locks to all parents irrespective of whether or not they have firearms. And that's a concern to firearm owning parents because many don't want their ownership status recorded in the electronic health record, just to give you a flavor for the types of adaptations. So in conclusion, we now have a set of implementation strategies that are ready to be tested to accompany this adapted program. And our next step, fingers crossed, is a hybrid effectiveness implementation trial. So I just want to thank the many people who have made this work possible and for the invitation to speak today. Thank you.
Thanks, Rinad. So next I'll introduce Dr. Ben Hoffman, who is one of our stakeholders and as a pediatrician and the chair of the AAP's Core Injury and Violence Prevention Program.
Thanks. Hopefully my slides work. That should be them there, yeah? It's okay, no worries. It worked. All right. It's amazing to be here. The only thing I really have to disclose is that I am really not a researcher. I'm a pediatrician. And I've gotten involved, I've been fortunate enough to get involved in some projects and be able to help me with some ideas. But I want to think about this from the perspective of healthcare. And what I want you to think about as I'm talking is the difference between healthcare and health, because that's something that I struggle a lot with, both literally and figuratively. As Pat said, he didn't really say, I'm a pediatrician at Oregon Health and Science University in Portland, Oregon. I don't know if anybody's ever had a chance to visit, but our children's hospital, Dornbecker, is here, the only vegan, free-range, organic children's hospital in the country. Everything on Portlandia is true. This actually is Dornbecker on the one sunny day that we're allowed to have. It's gorgeous. If you're ever out, let me know. One of the things that I love about Dornbecker is that in the lobby where that bell is, there's a Starbucks, and just next to the Starbucks is our safety center. And I'd be happy to talk to people about that. So, Oregon has the highest proportion of unimmunized kindergartners in the country, mostly due to parental personal objection. And you can see the quote from the director of a nonprofit where she said that vaccines are more contentious than abortions or guns, which is true. This is not Oregon, although it easily could be Oregon. This is California, in what Richard Pan has been dealing with. That being said, last weekend, somebody with measles came through the Portland airport, and we now have 3 weeks of measles watch. And I have to have a conversation every time I'm in clinic with families about immunizing their kids. And unlike in most of the country where I practiced prior, it's not, here's what we're going to do today. It has to be a conversation. And there's an expectation that it's going to be contentious. And I want you to think about what would happen if we had a conversation about the measles, mumps, rubella vaccine. And my response was, it's really important that we do it. What I can do for you here today is give you the mumps part, which is not the part that you are going to be most concerned about, right? I can give you the mumps part for free. But you need to go someplace else and pay for the measles and the rubella. Right? Think about the barriers that we place upon people even having conversations about guns in clinical settings and what we're actually able to do. So I do think it's essential that we engage primary care in the work around injury prevention broadly and in gun injury prevention specifically. Paul Wise is an absolutely brilliant pediatrician at Stanford. And those in the room who either are a pediatrician, know a pediatrician, have ever been to a pediatrician, there are no truer words than this. So I want to go really quickly through what AAP policy, American Academy of Pediatrics policy says about firearms. And this is from our policy statement, which was published initially in 2012 and then revised in 2017. And this is probably, it isn't probably, this is the single most controversial thing. And I've even had conversations about that here today with people. And I think it's hard to argue with the simple fact that if a child is not exposed to something, there's 0% chance of them being affected by it, whether it's, if kids were never in cars, kids wouldn't die in car crashes. If kids were never in water, they wouldn't drown. And I know that there was a ton of debate. I was not involved directly in this, but there was a ton of debate at every level about whether or not this should be there and how it would be perceived. We do know that firearm injuries are often fatal, that having a gun in the home, especially for older children and youth, increases the risk of suicidality, that access to guns can increase interpersonal violence risk. We recommend very strongly, based on good data, that pediatricians should have a conversation about gun ownership and counsel about injury potential, including suicide. And then we talk about some policy stuff, including the idea that guns should be regulated in some way in terms of design, et cetera. We know that, that safe storage is important. We know that we need to support research and surveillance, which is part of why I'm so delighted to be here. And we know we need to teach physicians how to do a better job. And I think this is the most important thing. It's scary, though. Many of you are aware of what happened in Florida, where there actually was a law on the books that threatened a penalty of $1 million and up to 5 years in jail for any physician having any conversation about any firearms with any patient. Subsequently been overturned, thank God, but it's scary. So how do we have that conversation? How can we facilitate? What do we need? What do me and my colleagues need to be able to do this? I think number one is we have to figure out how we meet people where they are, not where we want them to be. And I'll be honest, I may get in trouble for this. I think our policy statement, which starts that you shouldn't have guns in your home, for people who feel strongly about that, is problematic. And it creates this sense of confrontation. Having that conversation on my turf, where they know I'm going to be preachy about immunizations and car seats and all this other stuff, puts people on the defensive at the beginning as well. I think we need to normalize the conversation. This needs to happen each and every time. And it shouldn't just happen in the context of primary care. It should happen in the context of acute care. It should happen in the context of emergent care. It should be part of what we do, woven into our DNA. And we need to be able to have conversations with folks that get them to yes. I have yet to meet a single parent or caregiver in any capacity who would be okay with their 3-year-old child or grandchild accessing a gun without supervision, or their 14-year-old or 15-year-old accessing a gun without permission and supervision, especially if there are behavioral health issues. We need to start from these positions to be able to do it. We need to recognize that there are really three ways kids die from guns: suicide, unintentional access, and then the violence. The violence piece is the hardest. We all know that. It's also the hardest thing to think about addressing in a primary care setting. And I need to add on to what Rinad was saying. I get 20 minutes for a well child check because that's what the health care system says I have to do. So meeting people where they are is a very big difference between this family in terms of how I have the conversation and what we talk about, and this family and how we have the conversation and what we talk about, and this family. This is a guy at a Kohl's department store. Very different. They start from very different places. How do I meet them where they are? We cannot have it be us versus them. And I think that that's where my experience is, that's where most families come in feeling like it's going to be us versus them. That's what I feel like every conversation about immunizations in Portland is about. And we have to get past that. I don't have the answer. I have ideas. I think that's a part of the promise of us all being together. Because we all can agree, especially if we start with this. If we start with unintentional access in kids and youth who are at risk, we can all get to yes. And this becomes our vaccine. And I love the idea of point of service distribution of vaccines, protective mechanisms. But if you think about what we're doing with cable locks, and I say that with the utmost respect, and we've had this conversation, handing a cable lock to a family is like giving them mumps and making them go elsewhere to pay for the measles and rubella. The activation energy, the effort, I think we lose out a lot. And we need to think about how we give people what they want at the place where they need it. So how can we get them storage options that might meet their needs if they're hunters or if they own their firearms for personal protection? I also think that we need to start thinking outside the box. That I know that my relationships with my families, the families for whom I care, is deep. And that's part of what I love about what I do. But the likelihood of my really changing behavior in what may be a 1-minute conversation is pretty small. And if we really want to affect it, especially in the context of my 20-minute visit, which is all I'm allowed, we need to think more about how we engage healthcare providers in the provision of health as opposed to just the provision of health care. Because I can have a much bigger impact potentially if I go out and meet with Rotary and talk to people who own guns and work in communities. And even little things, like if my hospital had a sign on it that said, this is a gun-free zone, it gets in people's heads and they start to think about it, it normalizes it, and you get to have that conversation. And I don't think that that's where most of us start or even ever get to when we're thinking about the role of healthcare providers, whether it's pediatrics, family medicine, nurse practitioners, et cetera, in this work. And it's never gonna be one thing. Right? It's never, like, my conversations are never going to make the difference. My conversations plus handing out a gun vault are never going to be the thing. But my doing that, plus working with community-based coalitions, plus working with policymakers, plus working with stakeholders and gun owners and communities to really impact the health in my role as a healthcare provider, I think is really where we need to go. Because this isn't helpful either, and that us versus them. This is ultimately who I want to answer to, and out of all of images I've shown so far, this is the scariest thing, right? I don't want to have to look them in the eye and say, we failed you, because we can do better. And I'm thrilled for the opportunity to be here, and I want to thank everybody for everything they've done to this point and look forward to what we can do together going forward.
Lainey, you have a few questions?
Hi, everyone. Can you hear me? Yep. Okay. There was a question about how hospital systems might gain access to your intervention, Project Interact.
Well, I think first we have to show that it works. So I think we're in the, as I said, there's a lot of work to be done in the interpersonal violence realm about figuring out exactly what works with firearm-specific outcomes. I think once we've shown efficacy, then I think we talk about how to then implement that in healthcare settings and do some of the work that Rinad is doing kind of at the implementation, translation end of the spectrum. But as Dr. Cunningham just reminded me, Safer Teens, which did have general violence outcomes, is available. And we do have a website, actually, saferteens.org, that has an implementation package on it. And we spent a good deal of time developing that with stakeholders and figuring out how to implement that practice into emergency department settings.
And our CDC funding.
With our CDC funding to do that, yep.
Great. And another question about the Interact intervention. What steps have you taken to help ensure cultural sensitivity in your intervention materials?
Yeah, that's a great question. So as with all of our interventions, the messaging and the components of the intervention that we developed were reviewed with youth, adolescent youth from the community in which we are doing the intervention to ensure that it has both cultural relativity and sensitivity.
And there was a statistic presented that there's been a 56% increase in adolescent suicide rate. Was this increase across all methods, or was it specific to firearm suicide?
I believe that it was across all methods, although Dr. Horry might be able to speak up since that's a data set that she oversees. But my understanding is also that suffocation is increasing, particularly in females, as a means of suicide.
Since 2013, there was a 33% increase in firearm suicide among youth under the age of 18.
And more broadly for the panel, what have you learned that has been most surprising to you as you've conducted this work?
I think for me, I have been incredibly humbled and thrilled by the partnership and the support that I've gotten from community stakeholders who've wanted to teach me about how we might go about implementing such a program. I've had the opportunity to partner with stakeholders that I never imagined that I'd partner with. And I think together is how we're going to keep kids safe. And that's been a wonderful experience. And it was something that was unexpected.
Yeah, and I would echo that. I think it's the surprise of finding people who are willing to have the conversation and grateful for being able to have the conversation in a way that keeps everybody safe, that recognizes everybody's, why they're there in the first place, and that idea of getting everybody to yes has been a really powerful tool.
And I'll just add that in our work with adolescents in the emergency department setting, I think one of the things that surprised me the most is just how few opportunities these youth have when they come into the emergency department to tell their story and to have people listen to them and want to do something to change and help them. So that's been really, I think, an important part of the work.
So what tools can we use to increase the use of safe gun storage options for families?
So I would say you have to start with asking them what they want, as opposed to assuming we know what they want, or we will give them something that we can afford, because I think the expense of that ends up being failure. I think having those conversations, understanding the motivations for gun ownership, the different types of firearms that might be present in the home, and thinking about different opportunities and making it easy, available, and cost-effective.
And I would just add, there's a number of existing resources, so I think it's important that we not reinvent wheels that have already been created. For example, the FACTS website has a handout that the Michigan crew has developed to share with parents around safe firearm storage options. Additionally, Project Child Safe is a website that has information about safe firearm storage options, and it's developed by the NSSF. So it has the added benefit of being seen as a credible messenger of that information. And so I think there's a number of resources available, many of which are linked to in the FACTS website that I'd direct folks to.
Okay, and then we have a question about the setting of the intervention. Why in the doctor's office? Why not start in the gun stores instead?
So I think there's an opportunity to intervene across all settings. So I don't think it has to be limited to any one setting. But I do think in healthcare we have a unique role to play in intervening with youth who are at risk. I think I talked a little bit about this in my talk, that the emergency department, the time that an adolescent spends in the emergency department, can be a very powerful time for intervention, where it's a teachable moment and we can enhance the outcomes. I think the same could probably be said for the role of the pediatrician in their clinical space. And so I think healthcare has a vital role to play in this space, but it's not by any means the only space. I think there's certainly a role for community-based interventions that could start at the sporting goods store, as well as some of the other interventions you heard about in the prior talk in schools and communities that are currently being done.
Yeah. I mean, I would argue that it's necessary, but it's completely insufficient, and that we know it's never going to be one thing. There's not one simple answer, so it needs to be everything. And the more layers we can take advantage of, starting with point of sale to reinforce that booster shots, like reinforce those messages, reinforce the opportunity for resources, and encourage the right behaviors, the safe behaviors, the better off we are.
Thanks, Pat. Ditto to everything that's been said. And if there are any firearm retailers out there that want to do that study, I think there are many of us who'd be really excited about that opportunity.
So I think I'll throw in one last comment here before we thank the panel, which is not a question, but I'm just going to throw in my own comment here because I can, which is, I personally, there's a lot of pediatricians in the room. The AAP has been integral to this conversation for decades. I understand why they got to the statement that they start with, but I personally don't. I think we need to move away from that statement. That statement is not the way we talk about families who have pools in their backyard, which increases their death risk for their children. It's not the way that we talk about families who choose to put their kids in different forms of transportation. It starts from a place that is not a helpful conversation. And I think we need to move away from that framing of this is not a safe home to a whole different conversation about, we know you have a pool, so how can we help your kid be safer with the pool that you have that we respect your right to have, and that is available to many people across the country who want to own backyard pools. And so I want to encourage the pediatricians in this room who have a voice in AAP, and I've said this often with AAP as well, to really rethink that framing and how it's fitting into our communities across the country as we try to move to a conversation that it doesn't start off offensive at the start.
Right. Can I just respond very briefly? I completely agree. And one of the things we have worked very hard on the last couple of years in the context of drowning and safe sleep stuff specifically is really engaging families in the process of policy development and stakeholders in the process of policy development in a much more rigorous, specific way. And what I can promise is that I will do everything I can going forward to ensure that we continue to do that and we start from the place where everyone is safe.